Hello, my name is Nathalie Farpour-Lambert. I'm the president of the European Association for the Study of Obesity, as well as the head of the Obesity Prevention and Care Program of the University Hospital of Geneva in Switzerland. It's a pleasure to present the perspective on European models of care of obesity. The European Association for the Study of Obesity was established in 1986. EASO is a federation of professional membership associations from 34 countries. It's in official relation with WHO Regional Office for Europe. EASO is the voice of the European obesity community, representing scientists, healthcare practitioners, physicians, public health experts, and patients. EASO promotes actions through collaboration, research, education, and policy. His mission is to reduce the burden of unhealthy weight. The objective of the European Association for the Study of Obesity are to establish obesity as an urgent and relevant health and wellness priority, evolving evidence-based approaches for preventing and treating obesity across the lifespan, and to promote effective solutions through research, education, and policy. The European Association for the Study of Obesity runs many education courses, residential training schools in treatment and public health. Even if with the COVID-19 we had to change to online training courses. We have task force teaching courses, practical workshop, Center for Obesity Management Exchange and Mentoring Program, as well as national COMS training courses. I will also add the scientific masterclasses, courses with European partner organization, e-learning, and toolkits and resources. The European Association for the Study of Obesity has some priority action. One of them is the development of a network of specialist treatment centers. We have now more than 125 accredited centers, so named Center for Obesity Management, including 75,000 patients, and we have developed annual COM summit, national training program, as well as workshop, and we share PowerPoint presentation and recording session to enhance the exchange between COMs. The COMs exchange and mentoring program might interest you, so I just would like to present some details. It provides candidates to the knowledge, skills, and tools required to establish and run new multidisciplinary treatment center. The candidates can learn about COM structure, processes, and set up a procedure by visiting a COM center to observe and explore best practices. Ongoing monitoring helps new centers to become accredited members of the EASO COM network. And I would like also to mention that we have strongly supported the development of a European coalition for people living with obesity. It's for us extremely important to work with the patient, with the people who have obesity, and we develop all our educational program as well as policy program with them. I will now present some information and models of care for the management of childhood obesity. We know all that childhood obesity is an increasing problem in Europe as well as in the world. In the European region of the World Health Organization, the COSI study has shown that the prevalence of overweight might be higher than or close to 50% in some countries like Greece, Italy, Spain, and the prevalence of obesity as well as severe obesity is quite high in some of these countries, up to 20% of obesity. In Ireland, the prevalence of overweight is about 19%, and we know that there are about 8% of children with obesity, including a bit more than 1% of children with severe obesity. What are the treatment options for children and adolescents with overweight and obesity? We usually start, like in adults, with lifestyle intervention, including diet, physical activity, and behavior change, and including the whole family, especially in young children. We can add some pharmaceutical products, but to date we don't have many, so we'll talk about that later. And finally, in adolescents with severe forms of obesity and physical maturation, we can talk about surgery, and each case must be evaluated individually. In lifestyle intervention, we can use different components. Physical activity, it must be fun. It should include various activities, individually adapted, and including moderate to vigorous physical activity, which is beneficial for health. We promote active transport, leisure time activities, also with parents and young children, outdoor activities if possible, and we focus on the social integration in children in exercise courses and different types of activities. We know that physical activity is important to promote self-esteem, or increase self-esteem in these children. Regarding nutrition, we aim to a balanced diet, including fruit, vegetables, starchy foods, fibers, water, portion size. We work on portion size to reduce portion size. We also try to reduce the speed of intake. We work with the families about the place to eat, mainly in the kitchen or in the dining room, and not in front of TV or in the bedroom. We also work about the structure of the meals, to have a breakfast, a lunch, and dinner, and an afternoon break. We talk also about emotion, the link between emotion and food intake, and it's quite important knowing that about 30% of adolescents with obesity have eating disorders. We also like to unface the pleasure to eat, because in many families the food or the eating is a source of conflicts, especially in regards to obesity. Finally, it's really important to include a psychological component, working on motivation using therapeutic education technique or behavioral therapy. We must address psychological disorders and eating disorders with psychologists and psychiatrists, and we also address conflict issues within the families, the resource available around the child and the family, the support received, and if needed, we can also set up a family therapy. It's for us very important to promote health-related quality of life of families. What do we know about the impact or effect of lifestyle intervention in children and adolescents? With many Cochrane reviews have shown that, or several Cochrane reviews in different age groups have shown that the treatment effect is mostly more important in children between 0 and 5. It's less, the magnitude is reduced in children from 6 to 11, and bigger in adolescents 12 to 17. So we can get a change of BMI Z score between minus 0.4 to minus 12 or 13 in adolescents. If we look at the BMI curve in absolute number, this is the difference between the control group here and the intervention group, and I think it's interesting to see that we can still change the the evolution of the BMI in children with a lifestyle intervention. What we don't know is how long we can maintain these changes, or if we set up different intervention in a row, could we get more effect and then go back to I would maybe not say the normal, but to the overweight category for children who are in the obese category. We have a few data on pharmacotherapy in adolescents. The US FDA has approved orlistat, which is a lipase inhibitor for long-term use in children over 12 years, and phentermine, norepinephrine reuptake inhibitor for short-term use in adolescents over 70 years. In the largest of the RCT examining orlistat, the placebo subtracted BMI reduction at 52 weeks was 0.86 with orlistat, so it's not a major difference. And some gastrointestinal adverse events have been reported, mostly mild to moderate, like steatorrhea, fecal urgency, and flatus with oily spotting. There is no RCT of phentermine that has been conducted in individuals under 17. However, common adverse effects have been observed in adults, including tachycardia, hypertension, anxiety, insomnia, and headache. So we still need more research on safety and efficacy of existing and new obesity pharmacotherapeutic agents. What do we know about liraglutide for adolescents with obesity? The first randomized controlled trial has been published this year in the New England Journal of Medicine and has shown a change in BMI standard deviation of minus 0.23 at 52 weeks compared to zero change in the placebo group. So the estimated treatment difference is minus 0.22, which I think as a clinician is an interesting change. It's quite a great change. It's difficult to get it with the lifestyle intervention, except in young children. So I think it's an important research, and we really hope that the liraglutide will be commercialized soon for adolescents, who are approved for adolescents with obesity also in Europe. The problem is still the covering of the cost. In many countries in Europe, the liraglutide is not yet recognized by health insurances, and so patients have to pay it themselves from the pocket. Regarding bariatric surgery, we don't have also a lot of data, but mainly the teen longitudinal assessment of bariatric surgery, teen SLAB study, reported 3-year mean BMI reduction of 29% with Roux-en-X gastric bypass and 27% with vertical sleeve gastrectomy among individuals aged 19 or younger. So the 5-year outcomes in the Roux-en-X gastric bypass group demonstrated that the BMI reduction was largely sustained. So I think it's a very important and interesting finding. However, we must be conscious that adolescents with sustaining a bypass have micronutrient deficiencies, and they need a close follow-up. They need also additional abdominal surgical procedure. However, the long-term safety and effectiveness in patients undergoing bariatric surgery during adolescence are lacking. Last year, the WHO European region did the mapping of the health system response to childhood obesity and showed that the health system response to childhood obesity is lacking. The report highlighted several shortcomings in the area of governance, integrated delivery of services, financing, education of the health workforce. The main barrier were the fragmentation of care, shortage of adequate personnel inadequate funding for childhood obesity management and healthcare in general, insufficient collaboration among sectors and settings, and the lack of parental support and education. So we really need to work on the healthcare system and to adapt it to improve the management of childhood obesity. The primary care physician are definitely extremely important in diagnosing obesity in children. So I really encourage all primary care physicians to calculate BMI, to report it on BMI curve, to check if the child is overweight or has obesity early in life. Then the ideal would be to be able to collaborate with nurses, psychologists, dietitians, physiotherapists or sports teachers, social workers, and medical assistants to be able to set up a multi-component lifestyle intervention. For severe forms of obesity, I highly recommend to address the children to a tertiary center as well as obesity clinic. So because usually we face complex cases and we really need a full multidisciplinary team to take care of these children and their family. It's also important to have a health promoting environment, community support, and resource. For me, the training of healthcare professional is very important, and it's also essential to set up a surveillance system to know what is going on in regarding the prevalence of overweight and obesity in the population, and also to do some quality control of interventions. We have to aim for the quality of care and prevention of comorbidities. We have 2 years ago published a position statement regarding the recognition of obesity as a disease in children. We think it's partly important for increasing individual and societal awareness, early diagnosis and intervention, development of novel preventive and treatment approaches, and as well as new healthcare policies and education of healthcare workers. I will now talk about the management of adult obesity, which is has also some similarities. We all know that obesity represents an important burden in Europe. We know now that 23.3% of adults in the European Union have obesity, mainly in the northern part of Europe, as well as the eastern part. Which is what's interesting is that in children we observe higher prevalence of obesity also in Spain, Portugal, Greece, in Italy and Malta, which is not it's also the case for adults in Sicily and in islands south of the Mediterranean Sea. We still have unresolved issue in obesity management in Europe in adults, poor information for patients, delay in patient seeking medical and preventive care, a lack of knowledge and training, a lack of availability, visibility and accessibility to health resources in obesity medicine, incomplete multidisciplinary team, the same as in children, the lack of collaboration between physician and surgeon, specialized in obesity management, and finally, the lack of sustainable follow-up. The Action.io study investigated the weight loss outcome, and it's interesting to see that if we take a threshold of 5% of weight loss, only 11% of adults can maintain a weight loss of over 5% at 1 year, 26% less than 1 year, and 62% cannot achieve a 5% weight loss. If we set up a threshold of 10% weight loss, then only 5% of the patient can maintain a weight loss at 1 year. So in conclusion, our objective of often too high, and the objective of the patient also. What's interesting is it's to know how the patient with obesity and the healthcare professional perceive long-term treatment effectiveness. And you can see that patients believe that over-the-counter weight loss medication, as well as prescription weight loss medication, are effective, and they think there is a difference with healthcare professionals. Healthcare professionals think that visiting a nutritionist or a dietitian is important, as well as behavioral therapy. What's interesting is that patients with obesity have also high expectations regarding weight loss surgery, and they also are conscious that stress management and sleep quality management can have an effect on their weight. Actually, in adults, we have a few more treatment options. Again, lifestyle intervention, pharmacotherapy, and a few more drugs, and bariatric surgery. But the problem is there is a gap between them. With lifestyle intervention, we can get less than 10% weight loss, about between 10 and 20% with medication, and about 30% with bariatric surgery. The European Association for Study for Obesity has published guidelines in 2019 and has highlighted the importance to address pre-obesity, so to take care of patients with pre-obesity, and to reduce further weight gain in this population, and also to assess the natural history of disease and the transition from pre-obesity to obesity. Weight loss per se is not considered the first priority of obesity treatment for us. Rather, managing comorbidities and preventing weight gain or regain after weight loss is the priority. It's important at the beginning to assess endogenous factor, genetic predisposition with the family history, epigenetic factor, the family profile, physiological state like pregnancy, endocrine abnormalities, or other conditions. And also, it's very important to assess carefully exogenous factors, including the environment of the patient, the lifestyle, and energy intake, physical activity, eating behavior, as well as smoking cessation, sleep, stress, and also psychosocial factor or condition like depression, anxiety, psychosis. Some people may have a negative image of themselves, low self-esteem, and self-confidence. So we think, based on the evidence, that 5 to 10% weight loss over a period of 6 months is realistic and of proven health benefits. We have also published the ABCD for obesity, and we discussed the issue of the importance to make the difference between the fat mass disease, so altered and pathological mechanical forces, and but also to take into account the function of adipose tissue. And we know that people with the obesity develop a sick fat disease, so including deranged endocrine and immune response associated with obesity. We think that it's really important to take into account the context, including the cultural context, but also the physical context of the patient. We have extensively published in obesity management primary care, and you can find all this information on the EASO website. We have developed obesity management leaflet highlighting the importance to build motivation, to improve self-esteem, self-confidence, and quality of life in patients with obesity, to educate patients and health risk, and to assess motivation and health risk. Stigma has no place in treatment, so all practitioners must be careful about judging patient or stigmatizing patient. We have also highlighted the importance to take the history, take detailed history, and to do clinical and lab examination. As I said before, to treat comorbidities, and the aim is to prevent further extension of comorbidities or new development, and to yield compliance and adherence over the long term. Regarding lifestyle and behavioral therapy, it's very similar to children, so I will not go into details. So the take-home messages for the management of obesity are the type of intervention should be tailored according to the severity of obesity and its complication and discussed with the patient. Lifestyle modification can lead to moderate weight loss, but this moderate weight loss is associated to relevant outcomes. So either a weight loss of 5% is important and has an impact on the prevention of diabetes and its remission, as well as CV risks and death. Lifestyle modification can be implemented and managed at the primary care level. I just would like to highlight the fact that we have worked with the World Health Organization to include obesity in the International Classification of Disease 11. We're still working on the definition of obesity because to date the definition is not does not take into account the etiology, the degree of adiposity and health risks. So I would like to thank you very much for your attention. If you want to learn more about obesity, I would like to inform you that we start very soon, in a few days, the European Congress of Obesity and International Congress of Obesity together. It will be an online congress. You still can register, and you will have all the update about the recent research in basic science, clinical science, in children and adolescents, as well as health promotion and prevention. Thank you very much.